it.
All right. Greetings. Good to be back, and good to hear all of your beautiful voices. And this is an interesting problem that I faced, and I'm going to share that with you. And and I want to thank the panel, Sylvia, Ravi, Sriram, Roy, Joseph, and also Zubair for joining and discussing this case. And I want to thank my mentor, John Stroline, Mr. Charles Butt and the HEB grant, Angela Deal, and my university, University of Texas MD Anderson Cancer Center. So if you want to get a CME and if you're not, I'm not registered, I just created this YouTube link that teaches you how to set up your own CME stuff, and you'll get free CME from MD Anderson. So this is a patient that I've seen and taken care of last year, and followed her up just last month. So I thought that I'll tell her story. A 70-year-old with hypertension, diabetes, hypothyroidism, hyperlipidemia, and well-compensated child-stage cirrhosis. You know, platelets normal, PTT normal, albumin normal. So she was found to have a rectal polyp and 4-centimeter rectal polyp. And in May of 2017, she underwent a robotic transanal excision with primary repair. And the pathology revealed tubular adenoma with high-grade dysplasia, and the margins were positive. So she had a follow-up about 5 months later in December of 2017. And she was found to have a polyp there, and polypectomy was performed, and then the patient bled. What I was not clear talking to the patient and the patient's relative is why did the patient undergo an ileostomy? Usually bleeds don't require ileostomy. I wondered whether she had a perforation. So I didn't have access to the records. So I'm just making an assumption here. And I didn't have access to the path report from this December-ish procedure. In April, she had ileostomy was closed along with the release of adhesions. And in November 2018, repeat colonoscopy revealed rectal polyp, polypectomy performed, again tubular adenoma. Unfortunately, I can't give you more details because I didn't have details about the size and what was happening. And then she had another procedure in 2019, almost 10 months later. And then same polyp was seen, biopsies revealed tubular adenoma. All these procedures were done by one colorectal surgeon, except for 2019. And then in November 2019, she underwent transanal excision by the same surgeon of a 4-centimeter rectal polyp. And then after that, he called me and said, hey, I'm not very happy. I think I left some polyp behind. It was a difficult surgery. Could you please take care of this? But I don't recall actually when that call came, but she came to see me in August of 2020 when we performed endoscopy. So this is basically a low rectal polyp. advanced polyp, no cancer, had incomplete resection, recurrence, again resection, and a complication requiring an ileostomy. So that's the background story in somebody who is has diabetes, cirrhosis, etc. All right. So here is a lesion, and I'm going to play this, and I want Zubair to look at this lesion for a couple of seconds to get an idea, and then we can discuss. So what do you think, Zubair?
So I see a kind of a subpedunculated large polyp, looks friable, and also looks like it's had some it's easy to bleed as well. Like there is some bleeding going on the left side.
Mm-hmm.
And then I see some previous sutures as well that are, yeah. And it looks like that it has some high grade features just by looking at it.
Mm-hmm. All right. So let me ask Sriram to comment.
Yeah, looks like either a residual polyp or a recurrence polyp. So there is other than the semi-pedunculated, I don't see the pedicle, but it looks like from the appearance, it looks like it is floppy, but there is an extension to the right side, to the right of the screen, which is sessile. So, and maybe NBI will differentiate further. It does look like a villus or tubular villus appearance.
So Ravi, what do you think?
To me, it looks like a sessile lesion in a background of previous transanal excision. This probably is a residual, or most likely a residual lesion given the prior history of multiple attempts at removing it. Based on the appearance, I don't see any full convergence or loss of lobularity or depression on the surface, which might be concerning, but I don't see that here. Maybe I would want to go closer and look what's behind this lesion and to see if there is any extension. If possible, I will retroflex it. Based on the appearance here, it looks like probably a tubulovillous adenoma.
Mm-hmm. Sylvia. Sylvia, what do you think?
Well, I think that this is a very complex story. And at this point, macroscopic assessment of the lesion, although it's an important step, maybe it's not so informative anymore as the patient underwent two transanal excision procedures. So it's difficult to assess the risk of submucosal invasion in this case. And I would be concerned in this case that there is something more. There is a cancer already. So I would start with an MRI.
Okay.
Also given the location, because rectal polyps are known to have a more aggressive behavior than the proximal colonic lesions in my understanding. So I would like to rule out malignancy as a first step.
That is a very important point. I must admit here that I didn't do an MRI. I think given this history, if somebody faces the same problem, I think it's a good idea to do an MRI. to play safe. I think it's a good idea.
I completely agree that aspect of the conversation. There's no two opinions about it. I think we should be doing it. The other point, I mean, I'm concerned is that obviously he did what he did means that he knows what he's doing, and still a large polyp of this size is left at the time of transanal resection. So I was wondering if a majority of it is more of a the residual growth was smaller, and recurrence or the growth pattern is quite rapid, and that is what the importance of Dr. Silvia's comment of looking for malignancy, lymph nodes, and stuff like that for on MRI.
Mm-hmm.
Right. Okay. So this is what we did. The next is, we wanted to see, like Ravi commented, proximal side, how much is this the so-called sessile component, how much is a flat component. And as you can see, I'm pushing water, right? And I try to push water for two reasons, to see how big is the base, is it a big base or is it a narrow base, right? When you have a lesion that is non-dependent or whatever, or dependent, you put in water, you allow the lesion to float so that you can actually define a little more. If when we're looking at it, if the whole lesion is sessile with a big base, then the resection would be taking a longer time, more complicated resection. So using water to allow things to float is a good technique to incorporate into your practice, especially when you're dealing with a lesion like this. And you think maybe it is sessile, and how big is the base? Let me put in some water. The second one is when we put in water and the polyp looks like it is not in the, is non-dependent, it also helps you, right? When you resect, somebody who has had a bleed that required a ileostomy or whatever, you would know that if this lesion were to bleed, you can see the bleed because the lesion is not dependent. If it were to be dependent, you should make a point to rotate the patient so that you make the lesion non-dependent. That is one of the things you need to keep in mind when you're resecting large lesions, which are fed with a lot of blood vessels. And if they bleed, you can't see the bleeding point. So something to keep in mind. So Roy?
Yes, sir.
I want to hear your thoughts.
I think it's villous adenoma. I missed the first few minutes because I have to do a bleeder. Yeah, I think it's a villous adenoma. When the lesion is sessile like this, there is a chance that your surface prediction is not all that accurate because the cancer could be within it, and it doesn't transmit to the surface. But I heard that the patient is complex, so this is perhaps the best way to cut it.
So this is a patient that, if you missed hypertension, diabetes, cirrhosis, had 2 transanal excisions, 1 transanal excision complicated by a bleed/perforation requiring an ileostomy.
Okay. The more the reason to do it endoscopically, because obviously somebody doesn't know how to do the transanal one. In this particular case, I would inject with diluted epinephrine solution in order to prevent the bleeding.
What is your dilution?
I would inject probably about 5 cc straight, and then I would inject some saline onto it.
You will inject first 5 cc's of 1 in 10,000 straight?
Correct.
Okay. And then
something like that.
And then
I don't think it matters that much because when you dilute, also it seems like whatever you do is always causing blanching. So you can do like 1 to 10,000. You can do a little bit more. It's always seems to be causing blanching. So I don't know what it all means. Mm-hmm. But usually I just inject straight a few cc's and then inject saline.
Yeah, I'm glad that you bring that up. I want to hear what Sriram does and Ravi does and Sylvia and Selvi. You know, when you inject epi, how do you inject? It's a good point to talk about.
I usually take a 100 cc or if the patient has too much cardiac history, then I take a 250 cc saline bag and add 1 ampule of epinephrine. That makes it easier on the techs and also everybody to understand the dilution. If you put a 1 ampule of 1 milligram of epinephrine in a 100 cc saline bag, it becomes 1 in 100,000, and the other one becomes 1 in 250,000. And people have voiced problems even with 1 in 500,000. I think that will be dependent purely on the volume that is injected and also the patient's comorbidities. But the other point, what Roy was talking about, irrespective of the dilution, polyp blanches, because these are all micro capillaries that immediately go into vasospasm and there will be a color change. So we can't be counting on the color change. We just have to see how it works after you start cutting.
Sylvia?
Well, I think I still think that we see the top of the iceberg with this residual tissue. And to be honest, at the very beginning in 2017, this patient had a polyp with several high-risk features. I recall it was large. It was tubulovilus. It was villus component. It has a villus component and high-grade dysplasia, and it was not completely resected. Please correct me if I'm wrong. So, as we know from the Japanese data, within 3 years, 2-3 years, these polyps become cancer with these features. So I'm very concerned that we might treat the top of the iceberg. So I would still wait until we have more imaging data.
Right. Selvi?
I agree with what's been said, Raju. I generally just use one pre-filled syringe of 1 in 10,000 epi. I never use more than the 10 cc syringe. And I would inject the top of the polyp and then also definitely at the base. And I agree with the blanching. It always looks terrible once you're done. It's not just where I inject, but generally kind of in the vicinity, I'll see a lot of mucosal blanching. Thankfully, I haven't had any bad outcomes from that, but it definitely is something that gives me pause. And you don't know if you've done a good job with the epi injection until, as somebody said, after you've started cutting and you see what the bleeding outcome is. Thanks.
Ravi,
although it is concerning in this polyp, I fully respect Dr. Selvi's approach about the concern about cancer. There is no doubt about that with the way it is looking and the way it has evolved over the last 3 years. But still, I think whatever we are trying to do in terms of endoscopic resection, at least it would, even if we are unable to complete the resection, it would serve as a large snare polypectomy to a snare polyp biopsy to establish cancer so that subsequent decisions can still be taken the way it needs to be.
Yeah.
Also, this would serve as a kind of a debulking procedure for the patient. I mean, I can't imagine that they're not having maybe some bleeding or some kind of symptoms from a lesion that's this large. So we may just be kind of helping the patient treating the local lesion, even if there is cancer and it's metastatic.
All right. So how are you going to remove this polyp? Let me ask the group EMR, ESD, and how are you going to go about that? In your own practice, if you've seen this lesion, what would you do? Let's start with Roy and see what each one does. Because this is a lesion, right? We see the lesion, we have to go through the thought process, and we have to ask ourselves, how are we going to deal with this lesion? Right, Roy?
How far is this from anal verge before here Roy starts answering?
About,
how far is it from?
About 4 or 5 centimeters.
Okay, thanks.
No, Sriram, you cannot use your index finger to tamponade it if it bleeds. Just kidding. I think I would do piecemeal EMR. I would inject as much as I can, and then I would cut it piecemeal. The reason is that if I bleed, if I cut it in one piece, I just think that if there is a bleed, it will be. I need to have a trial cut to see how the lesion behaves.
All right. So you guys agree with that, or does anybody want to do an ESD?
I completely agree with what Roy said. You inject and see how it lifts, and
okay, all right.
Try to cut it in one piece or as a piecemeal.
All right.
Professor Raju, maybe may I ask a question?
Please.
Just I continue to play the advocate of the devil, but if we remove this remnant, there will be local inflammation, and if we do the MRI, the radiologist will not be able to assess it properly. So again, we will delay the diagnosis.
Right, you're right. You're right. Actually, I'm glad that I'm presenting this, and to be honest with you, initially when I saw her, when the guy presented to me, the colorectal surgeon, he told me there is a small polyp.
Yes.
So I already brought her to the hospital, prepared her, and I said, okay, we're going to cut. If I'd known this, if I had this picture in front of me in my clinic, in at least 1 or 2 cases where I've actually went the route of getting an MRI to make sure there's nothing else with the rectal cancer protocol, and then go with either whatever needs to be done. You know, and what you say is a very important take-home message for all of us to keep in mind.
Thank you.
Right.
Yeah, I would like to underline that aspect of it. Is since this is a learning session, I'm just venturing out, pushing that point further. We all come into those situations where someone refers, and then because we deal with the more or less complex polypectomies, reasonably will be comfortable bringing them on straight. But there will be occasions where we should not hesitate. I'm not commenting on this case. We should not be hesitating to come out and have the conversation and do what is needed, and then go back again to do what can be done. And that the reasoning, rationale and reasoning is what Dr. Sylvia is mentioning. And for the continuing of this conversation is just presuming for hypothetically that the MRI is okay and this is something that needs to be dealt with for conversational purposes for the case.
Yeah, it's an excellent point. Excellent point.
Excellent, yes.
I think if the patient is on the table and it's already been such a hard thing to schedule and everything, one can do an endoscopic ultrasound, and that would be as
yes.
Yeah, of course for lymph node it will be less sensitive, but at least for bulky vertical invasion, you can see it.
Yeah.
If at all, it will it will encourage you. If you do an ultrasound in a case like this, where it is already twice or thrice dealt with, it will only encourage you to postpone the case, because it will give you a false sense of invasion into the underlying tissues, even if it is not actually infiltrating because of the adhesions and the fibrosis in that region. Correct. It becomes very difficult to differentiate. And that is where Dr. Sylvia's advice of the MRI makes sense also, not just for the lymph nodes. So it's just a different point.
Yeah, I agree with that. So, so we went ahead and did the injection. And as you can see, we are using saline. I didn't use epinephrine. I used a saline with a little bit of methylene blue. And Zubair, as you can see, we got into the submucosal plane and we kept on injecting. I think we injected probably about 10 cc to get a good lift. Mm-hmm. And then we felt that, okay, the lift looked good, but we needed to inject a little more. And we went a little bit high because that was the flat component that actually did not lift well, as you can see. So we backed off and then we came to the other side and then we injected here. So as you can see, like we use the same technique, like, tap on the syringe plunger to get into the plane and then inject. I believe we injected about a 13 cc, I think 13 or 16, about that amount. We got a good lift. So the question is, how are you going to cut this? Okay, Zubair, you tell me how you're going to cut this. You got a nice lift. What is your snare? What is your current? And what's the technique you're going to use?
I will go with the large snare. I'm not very well versed with the snare sizes.
Okay, all right.
Yet,
okay, you
but
picked up a large snare, at least, based on the size of the polyp. Here we picked up a 15 millimeter snare. Okay. And what's your current setting?
I will probably go with 313.
Okay. All right. And in terms of the technique, I will show you what we did. And when you have a polyp like this, this is what we do. We use a 15 millimeter snare, and I set up 314, a little bit increased interval, so that at least I'll have more coagulation in between. And then I try to float the polyp to see that I can actually get my snare around. And by floating the polyp, you can see that, right? You can see the snare going around in a much more controlled manner. And whenever you see a large polyp like this, when we try to cut, sometimes we cut at an angle, but not necessarily going to the base. So by using a lot of water, we allow that polyp to float and let it come into the snare nicely. You see that? So that is something important to keep in mind, right? And then we get to the base. And then we used 314 endocut Q, that is effect 3, duration 1, interval 4. And one thing is important is rectum has a lot of thick tissue or thick wall compared to the cecum. And it's also important to keep in mind, how do you close your snare, right? It's not just your current, whether you keep the snare very tight and cut it fast, or you let it cut, the current to cut, and you slowly close the snare. That is something I don't know how to teach. You know, that's a very important thing. It's the duration of the current that you deliver to the tissue. That is something people need to learn as they go along. Because if you learn that technique about the optimum way of closing the snare, you prevent from large bleeding, because the vessels will get coagulated before the tissue gets cut. So this is what we see.
Mm-hmm.
And then we decided to cut the remaining one. You can see that there's a small amount here. So you can actually take the same 15 millimeter snare and cut it. You know, you'll save you know, unnecessary expenditure to the patient. But when I see a smaller polyp like that, I struggle to cut with my 15 millimeters. So I try to go to a smaller snare, which gives me better control of my cut. So I picked up a 10 millimeter snare and used the 10 millimeter snare to cut the remaining portion. The reason I was not trying to get the whole thing is I knew that the right side will not come into the snare. So I thought that, okay, the so-called sessile component, let's cut it and deal with whatever is left later. So cut it into 2 pieces and see if you can cut it. As you can see here, I got my snare. With a smaller snare, you have much better control. But as you can see, as I'm closing my snare, some of the tissue is escaping from my snare. But that's what happens when there's a lot of scar tissue underneath. Mm-hmm. So now you see what is left. What are you going to do? Zubair, are you going to do APC? Are you going to do hot biopsy emulsion? Are you trying to use a snare and keep on cutting? Are you going to use a cold snare to keep on cutting? Yeah, you know, we have several different options to remove this portion. So
I think I will probably go with APC.
You'll go with APC?
Yes.
Okay, that's one option. I think people have described that as a technique. And if you look into the literature, there was a control study very early on from St. Mark's, where they've shown that ablating with APC cuts down the recurrence rate. But if you look into that study, I don't know whether we can actually apply the same settings what they've used then to now, because they use pretty high settings. Almost like 50, 55 watts for APC. All right. So Roy, let me ask Roy, Sylvia, Ravi, Sriram, Aman, Joseph, what would you do? How would you manage this?
So I have a few comments. Number one, you cannot just take any large snare there is. A flimsy snare will not work.
What is that?
Period. A flimsy snare will not work.
Okay.
So it's not just like you got to have some understanding of the snare types, and you cannot just like pick any snares. That's a comment to Zubair. And number two, as far as doing the APC by Irby will deliver the maximum amount of, will deliver the necessary power in order to coagulate the tissue. So there's the setting that you have, which is usually 50 or 60. Now with the newer machine has been reduced to 30. It's just the maximum setting. The actual power is determined by the machine. As far as I know, it never really reached to that high. So I always use 60 in the past. Now people say I have to use 30. I say whatever you want to set. It doesn't really matter because the computer will calculate it for me, and it never really reaches there. So that's two. And number three is that you cannot do an APC at this time. You must have a lesion-free area before you do an APC. So you must cut all of these remaining villus adenoma. And then once you don't see any visible lesion, then you do the APC. I don't do a falsion and all of these things because I think you still can cut using inject and cut.
Okay. All right. Let me see what Selvi would do.
So I agree with the comments with removing any residual polyp before using APC, but I do like to use APC. And I'm wondering if Roy or if anyone else on the panel has a good reference that Zubir and I can look at to differentiate different polyp types, or what's the best way for us to learn about, you know, flimsy versus stiff? Is there a reference that we can use?
Snare.
Okay, there are really three snares that you need to have in order to be functional as an EMR person. So number one is that the snare that you use for cold snare. So that's usually the flimsy one. It doesn't allow you to do hot coagulation. Usually you just want to cut a small SSA or an SSA or a small adenoma. So that's one. Number two, then you just need to have the stiff snare. In the US, we use the double braided snare, and we just need to have two sizes. One is small, which is 10 millimeter, and number two, for me, I use a 20 as my large one. It sounds like Raju used 15. That doesn't matter. You just need one small and one large. That's how I practice, and I just need three kind of snares, and that's it.
All right.
Great, thank you.
Okay, let me hear what Sylvia would do, and Sriram, Joseph, Aman.
I think at this point, I would wash out the area and carefully inspect the margins. Indeed, at 3 o'clock and 12 o'clock, it seems there is residual adenomatous tissue. So I will take the time and try to remove first the residual adenoma. And if needed, sometimes I would inject a little bit more and use a small stiff snare, as Roy suggested. And in the end, if there is no residual adenoma anymore, I will still use APC.
Okay, that's good.
Treat the margins.
Right. Okay. Aman. Okay. Sriram.
I agree. There is still some residual tissue, and that needs to be snared. How you snare is depends on individual preferences. I would like to inject on at 11 o'clock, 12 o'clock area, and also at 2 o'clock, 3 o'clock area. And if the snare that I have in my hand, the 10 millimeter that you used last time, is not usable, then I will use an X-Acto snare. That is what Roy was talking about with the cold flimsy snare. With it's a single wire snare, not a braided one, and that can flip and also bend. So I will be able to better maneuver for the small lesions to include certain healthy margin. And once that is done, APC, that part is already discussed. Only caution will be I would be cautious about those metal staples that might conduct energy deeper. So I want to be a little careful about that. And I think further injection proximally is the key to complete the resection. And the reason, so when you use APC in these kind of settings, we need to be clear in our mind, are we using APC as a way of topping it off to take care of any residual microscopic polyp tissue, or are we using it as a way of fulgurating or the residual tissue, macroscopic residual tissue that we are seeing? And the second approach is not good for this particular situation, because this residual polyp seems to be a little bigger and it can be snared. So what can be snared should not be fulgurated. And the other rationale is because this is already a third time a bigger resection, and we have achieved such great result out of polypectomy without getting into any of the perforations or the bleedings. So why risk recurrence?
Yeah, thank you. I think you made a good point. For the sake of Zubair, I want to stress it again. You know, whenever you're trying to do something, think about what is going on in the field. You know, as you can see here, there is a staple. So that led Sriram to think, hey, if I do APC, I need to be careful, because with a staple there and you apply APC or any current, your injury is not going to be not necessarily superficial where you intend it to be, but it can go deep. So that's a very important point to keep in mind. All right, let me ask Joseph, any thoughts?
Yeah, so the idea here is that all visible residual polyp, it must be addressed first. You have to ensure complete resection before you attempt either APC or snare tip soft coag. That's the only way for you to actually achieve the recurrence risk. So we have to address that.
Right.
I think the one other thing is, despite the previous endoscopic or surgical resection, the polyp looks like it can lift very well. So this residue, I think we can inject more to lift that area where there is no submucosal cushion, and we can clear the residual polyps with a small 10 millimeter stiff snare. Then once we clear all the residue, then we can ablate it with APC.
Okay. Thank you, Ravi. Okay, Sriram, sorry, Aman. Okay, all right. So this is what we did. I thought that I will, you know, when I saw this, I thought that maybe it will be tough given how it lifted. So we decided to do hot biopsy avulsion, and I realized that this is a large area to avulse, and one has to take a lot of time, and you need to have a lot of patience, and then try to go step by step. It took almost probably 20-30 minutes for me to do this. I actually edited the video shorter just for the sake of this discussion, and I kept on doing it. And the second thing is this lesion that I'm removing it with my forceps, I put it in a separate jar. So I tell my endoscopy nurse to document, okay, rectal polyp, the snare section one in jar 1, and the rectal polyp margin, that is jar 2. So that's what we try to put it in when we put the pathology. As you can see, the lower margin was cleared. The upper margin is more fibrotic. You can see my clip kept on slipping, and I had to work hard to get a nice deep grip.
I have a question.
Go ahead.
Before you did the avulsion, did you even try to use a small snare and the 10 millimeters?
I tried to use the 10 millimeter snare, and that kept slipping. I just deleted that video. I didn't put that video in this discussion. And then I said to myself, you know, I will not get anywhere with the snare, so I decided to do hot biopsy avulsion.
Did you try to use flipping the snare or snaring from the side?
Yes. Yeah. Yeah. The problem is, as you can see, there's so much of fibrotic tissue. You can see just white tissue there. Yeah. That's why I kept on missing that. So now you can see that I felt that, okay, it was all visible tissue has been removed, from this polyp. And actually, I can actually post the original video. I think I posted the original video. It's in August of 2020, where I basically did not remove the portions that I removed for this case. And as you can see here, you can see some clips there, right? Not only at the top, but the top margin towards 9 o'clock of the resection. So then we did the APC, and so as you can see, we set up a setting of 0.8 liters, 35 watts, forced APC. I don't use pulsed. I prefer to use forced. That's what I've been using for the last 10 years. And one thing is, whenever I think that there is a lot of scar tissue, I don't do just APC for the sake of APC. I want to get a brown effect because I want to get a deep thermal injury so that if there are cells that are stuck in the scar tissue, I want to get rid of them as well. So something, that's what I do. As you can see in the lower margin, I was happy. It's much more clearer, less scar tissue. And I didn't apply the APC multiple times. I was just applying once and then moving. But the upper margin, as you can see, I tried to apply spot on spot to get, there's a clip there, as you can see there, there's a clip. So we try to apply more. You may not get that type of deep burn with snare tip soft coagulation. Although people have shown snare tip soft coagulation versus placebo is helpful in preventing recurrence. There is no comparative study between APC and snare tip soft coagulation. And with snare tip soft coagulation, you may not get this well-controlled deeper burn that you see here. That's at least my feel, I can't prove. So that's what it is. Okay, I want to hear your comments and then we can see what we did next. Are you happy with that, Roy?
Very nice.
Looks good. I still believe that patients don't go to MD Anderson to hear that their endoscopist was able to manage saving $50 by not using the APC catheter and rather using the snare tip so that the institution can save like $20, $30, $40. They come there to get good results. And, you need to get good results using a spray coagulation. And that's why you use an APC rather than a pinpointed coagulation.
Okay.
In the business sense, it's really like a wrong way to try to save the cost of endoscopic resection by nitpicking the small amount, small cost items. If you want to save money on something like this, then go do the sedation by yourself. Then by not having the anesthesia, you save like probably thousands of dollars.
Thousands of dollars.
So,
yeah.
so stop thinking and believing that you're saving a lot of money by not using an APC probe.
That's one of the great things about MD Anderson, and I'm sure hopefully many academic centers, is that they don't make those restrictions on us. They just want good outcomes and they want excellent care of patients.
Yes.
And so we're not restricted by that. I hope that nobody is restricted, regardless of your practice setting. But I think that's one of the great things about working at MD Anderson.
No, I'm just being facetious, but also being real.
Right.
Because that is not how in business how we think about savings. There are like principles for it, and it's just a couple of endoscopists just wanting to be more well known by showing, hey, I can use this snare tip to do these things. Whatever, more glory to them.
Right, exactly. Because look, we're actually, I mean, if you look at it from a business sense, we just saved this patient another surgery, another operation, and think about the operating room costs, talk about anesthesia costs, like that's a whole other kettle of fish.
Plus quality of life, plus other factors.
Agreed. Just my 2 cents.
In the chat, Laura posted a chat saying that Olympus has a 10 and 15 millimeter snare, hot and cold. Laura, you want to comment on that?
So the new Snare Master Plus, now we have to go into the company specific, is I think it's braided, but it's softer. So it can be used for cold snaring, and at the same time, it can also be used for an SSA. You know, it remains to be seen whether you can do a complex case like this, and you would want something that's softer. We usually don't want to use a softer snare.
Yeah, actually, it's very interesting. I prefer for my EMRs the stiff braided snare, that is the Snare Master, not the Snare Master Plus. I wish Olympus did a little bit different. Rather than saying Snare Master Plus, they should have said Snare Master Hot, Snare Master Hot and Cold. Because people, when they're picking, if you ask Snare, hey, get me this snare, and I say, okay, we're doing EMR, they pick whatever is out there because the Snare Master Plus is not that easy to read. You know, and if you have a new technician who doesn't know the difference, he may be picking what you don't want. And I wish they labeled it as Snare Master Hot and Cold, so that it's easy for anybody when they're looking at the envelope and make the right choice.
Hi, Dr. Raju.
Yeah.
Good morning. Actually, you know, in the package, it does say hot and cold.
Is it visible easily?
Yes, it is visible. It is.
Maybe I should look at it myself. So I think I'm glad that you brought it up because so that's a good point. I'm glad that you brought it up.
Let me just comment very briefly about the use of a stiff snare. So the idea of using the stiff snare to purposely resect at the level of the submucosa, you know, was best exemplified by Suhendra. I mean, Suhendra used to do these EMRs without injecting. And he used a specialized snare to do that. And many of us, if you ask Sriram, for example, who spent a long time with Suhendra, he would say, you know, we in the United States learned the EMR after him as well. And we actually had to adapt because the only snare that we use today is not even as stiff as the Suhendra Erlangen snare. So now if you say, oh, could I use something that's not, that's less stiff, such as the hot and cold snare, you can try. If I have to guess, you probably could resect some, but there'll be cases whereby you're not going to cut at the right plane because your snare is just not the right snare. If you use a flimsy snare, I cannot, of course, define what snare that is, but it's a really flimsy snare. You have no chance. It's like going to war with people having a machine gun and you come in with a knife. That's just not going to work.
It works if you know how to throw your knife. Anyhow,
yeah.
No, actually, Roy made a good point. Actually, there is a control study where they've used a hot snare versus cold snare in terms of the depth of the resection and whether it includes the muscularis mucosa in the resection specimen. So with a cold snare, you may not be able to get the muscularis mucosa. That means you're not going to get the whole mucosa. So something to keep in mind. I want to take I want to ask Joseph to comment because he made a good point here. For trainees, might be good to use a precise APC mode. Why don't you explain that?
Sure, yeah, so there's different, of course, there's force, pulse, and precise APC modes. What's nice about the precise mode is that one, of course, you still get this continuous application of the energy, but as you get, essentially as you get closer, the intensity of that energy diminishes so that if you're in contact, you're not still forcing that energy through the, into the mucosa. So it's almost like a sort of a fail safe, so to speak, if you touch the mucosa and you still have your pedal on accidentally. So that at least in the beginning, when they're still learning kind of tip control, it might be that might be a good option.
Yeah, it's a good point. Thank you. All right. So we decided to close. And whenever I see that I'm dealing with a lot of fibrotic scar and I'm applying too much force with my open clip, I try to use the Microtech clip. And they tend to, the blades tend to still remain intact. I've had a little bit of a problem when I used resolution in a fibrotic scar where the blade could actually bend back. So something to keep in mind if you see, I'm applying a lot of force there and I'm trying to close the defect that has a lot of scar tissue underneath. So in that case, this is something that I prefer. And as you can see, it's very close to the anal canal, right, Sriram? So that's where we stopped the closure. The lower portion, I left it alone. So in summary, basically, this is the endoscopy report. I just want to share how, for a trainee, how you should put a report. You want to say the site size, Paris classification, NICE classification, local scarring, clips and everything, right? And then it took 51 minutes and this is what we use for injection. These are the snares that we use. And this is the current that we use for the snare. And this is the hot biopsy avulsion, Ravi. It's effect 1, duration 4. And again, interval, I just put it 1. So I'm just wanting a longer duration to cut through the fibrotic tissue and APC and the number of clips. You want to put the whole thing in your report. And most important is take a lot of pictures. And I basically cut and paste all the pictures that I've taken for this thing because I want to use this for my own learning. If in case the polyp came back, where did it come back? And I can learn and improve. So important to take a lot of pictures. And one thing is if you're using the Provation, you could ask the Provation guys to maximize the number of pictures that you can include in your report. Initially, it was about 20 or something like that. When we set it up, we asked them to get it to the maximum. The maximum they give us now is about 72 pictures. So I try to use as many pictures as possible. And then, as you can see here, this is the whole story, right? So this is the pathology from the main polyp, villus adenoma with focal high-grade dysplasia, no cancer, low-grade dysplasia at the edge. And the margin that I did the avulsion, basically villous adenoma with cautery artifact, no high-grade dysplasia, no invasive cancer. And 6 months later, we brought the patient back. And this is what you see. That's the scar tissue. Those are the clips, as you can see here. And you don't have, at least no recurrence. Right, you see those clips, right? Those are the clips that we worked on. And so I try to go very close. And as you can see here, I'm taking multiple pictures and in different angles so that it is a good documentation. You know, this polyp, from the endoscopy point of view, this polyp has no recurrence. As you can see, because of scar tissue, it's very hard to take biopsies. We just took a couple of biopsies. I'm also worried about ripping tissue and given the previous history of problems. So we just used a little bit. I was satisfied that there was no recurrence.
Nice.
I think it is much closer to the anal verge than originally thought, and I think you saved the patient from a colostomy.
Right. So, and but what happened was this time I went back and did the whole colonoscopy because the first time we just did a rectal resection without doing the colonoscopy. The first one took about 51 minutes. This time we went to the cecum. And on the way back, we cleared the polyps. Cecum, just 2 millimeter polyp biopsy, no adenoma, must be some edema, whatever. Ascending colon, EMR, tubular villus adenoma is again about maybe 7-8 millimeters. Transverse colon, traditional serrated adenoma, transverse colon, 2 millimeter polyp, cord biopsy, tubular adenoma, splenic fracture, EMR, hyperplastic polyp with lymphoid aggregate, descending colon, 3 millimeter polyp, early hyperplastic, sigmoid colon polypectomy, tubular adenoma, EMR scar, just crypt distortion. And for the sake of Zubair and any other fellow, again, as you can see here, so I cut off all the images and just focused from here, rectum scar. I took a lot of images, right? You know, when you're doing something like a tumor resection or whatever, the best way is to have image documentation. And taking multiple images is something very important. Even if you don't want to label every image, I put it here, rectum EMR scar images 40 to 48. So that's how I try to save my time. All right, and so why don't I just leave it open, and I would like to ask Sylvia to summarize, and if there are any comments we can take, and then we can take it from there.
Well, I think the case has been already summarized. The last slide is actually complete. We started by evaluating the residual polyp and assessed the risk actually what is real life. We proceeded by endoscopic resection, assuming there were no lymph nodes. It was a benign lesion. And we have learned that patience again and step-by-step approach always helps to remove such residual adenomas.
Thank you so much, Sylvia. Thank you for the beautiful summary. Any other comments? Roy, Sriram, Salvi, Aman, Joseph?
And this is excellent case where colorectal surgeon is reaching out to a GI doctor And in the community, I generally don't see that happening. Generally, if the colorectal surgeon is not able to do something, I think they have to swallow their ego. So I think I give kudos to this colorectal surgeon to not have an ego and, you know, send it to an endoscopy, because otherwise I see them referring only within surgery, not to GI for something that they could not do. The way they sell it and what I see around is, you know, they'll say, well, this was technically difficult, and I think it should be done at a tertiary care center by another surgeon, you know, so, but they would not send it to GI and community. So I think despite all said and done, I think I still give kudos to the surgeon that he thought the best interest of the patient and he sent it to a GI doctor.
Good point.
All right. Troy? Okay. All right. Thank you so much. I really appreciate it. We certainly learned a lot. I think for the sake of trainees, beware, low rectal region, big lesion, make sure you don't forget about doing an MRI first. I think it's a good take-home message for me. All right. Thank you so much. All right. We'll see you next week.
Thanks a lot.
Bye-bye.
Bye-bye.
Bye.